Thank you for joining us today. I want to welcome everyone to the November installment of the STS 2021 Webinar Series. This webinar series runs every month and features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic for this month is tricuspid valve disease treatment, surgical or transcatheter. Please note this webinar is being recorded and will be available tomorrow morning on the STS website, STS YouTube channel, and as part of the STS Hot Topics podcast. At this time, I am pleased to welcome our moderators for this session, Dr. Gorav Ailawadi, Dr. Tsuyoshi Kaneko, and Dr. James Gammie. Moderators, welcome. I will now turn it over to you.
Great, thank you. My name is Gorav Ailawadi. I want to thank everybody for joining on late on this Thursday night. We do have what I believe is going to be a really exciting discussion. As you all know, tricuspid valve disease is really a hot topic, and we're going to focus on two specific areas, both with the recent clinical trial data on how to handle the tricuspid valve during mitral valve surgery, data that just was released this past weekend, as well as the whole landscape of transcatheter devices and where they might fit in our treatment of patients with advanced tricuspid valve disease. So I'd like to introduce my co-moderators, Jim Gammie, who's at Johns Hopkins Hospital and University. He will talk about, of course, data that I just mentioned that's really late breaking, and Tsuyoshi Kaneko from the Brigham and Women's Hospital. I'll also go ahead and introduce the rest of the panelists. Leora Yarboro from the University of Virginia, Molly Szerlip, who is a really leader in interventional cardiology and interventional tricuspid valve disease, and Becky Hahn. I believe most of the surgeons out there know Becky Hahn at Columbia University, who's really a world-class echocardiographer and has taught us a lot about how to image this challenging valve. So without further ado, we're going to go ahead and start with the first case. And I believe Dr. Yarboro is going to start on a surgical case.
Thanks, everybody. It's a pleasure to be here. I was asked to present a case of that came up recently, actually, somebody with degenerative mitral disease and had a concomitant tricuspid issue. And so just to present the case here, this is that of a 70-year-old male, history of hypertension, moderate to severe pulmonary disease, liver disease, and severe pulmonary hypertension, who presented with severe mitral regurgitation and P2 prolapse. He also had mild tricuspid regurgitation and annulus of about 3.9 centimeters. And here you can see his disease in the mitral position. And again, not too much TR, but a mildly dilated annulus there. And there's his mitral disease. And so I just have a few slides just to present the case. And I might just pause here for a second just to ask the panel, is there anything in particular that stands out in this case from a tricuspid standpoint where you would initially jump on?
It's a good question. I don't know, Jim, you want to take a first stab at it?
No, the TR you said was mild, and the RV function was normal. And what were the PA pressures?
So the PA pressure is about 2/3 systemic there, with severe in the setting of severe mitral regurgitation. We can show it to you.
And then when you say liver disease, is it liver disease by?
So changing, so some cirrhotic changes on CT scan, but not any functional disorder.
Yeah, and I mean, when we think about the tricuspid valve, even this description that you're presenting here, mild tricuspid disease with an annulus of 3.9. Typically, I mean, that wouldn't necessarily meet even the guidelines for necessarily intervening on the tricuspid valve unless the patient's BSA is quite small and their indexed annular dimensions are large. So, you know, I think there's this patient, you know, when we move into Dr. Gammie's discussion, would not necessarily even qualify for that the CTSN trial. However, if they're a small patient, then they might.
And I agree. And so I'll move on with the case here. This patient was ultimately treated with a MitraClip as it turns out, I think due to the comorbidities there, and then later presented afterwards. Unfortunately, there's 3 clips placed and had now still severe MR, as well as the degree of MS. And now this is the presentation here that you can probably see of the tricuspid valve, where truly moderate MR. And so this is the patient that actually arrived to surgery. And the view I showed you before was prior to the mitral intervention. And so pausing now here.
Can you maybe clarify for the surgical audience the decision that the patient should get a mitral clip versus?
So I was not part of that decision making, presumably due to the pulmonary disease. It was a higher risk patient, history of recent COVID, et cetera. So, yeah.
Laura, what was the RV function and pulmonary hypertension at this time? I can't see it being better.
Yeah, sorry, this doesn't play in a loop, but the RV function is preserved. Sorry, and then and pulmonary hypertension persists. So still, where it was before, 2/3 systemic, but a little bit more symptomatic. Certainly, from a shortness of breath standpoint, is why the patient came to us, and that keeps going back there. But
I'm curious how.
And then the annular dimensions.
So the annular dimensions are similar here. They're still about 3.9, maybe a little bit more evidence of RA overload. And then, of course, there is an ASD present from the mitral clip procedure.
And can you show us a little more about what happened in the mitral valve? Because it now looks like a much more complex jet.
Absolutely. It is. There's multiple jets across and degree of stenosis. I believe the gradient across that was about 6.
What was the interval between the mitral clip and representation?
It was about 3 weeks.
Okay.
All right, Leora, do you have any more slides after this, or is this where we decide?
This is where we discuss. Yeah. So MR in the setting of an acute decompensated patient with mitral clips on the mitral valve there.
So yeah, tell us about the presentation. You said decompensated. I presume they're
so more short of breath.
Not...
So felt actually initially okay after the mitral clip procedure. It sounded like, and by all accounts, the procedure itself was okay, although not perfect. But then had just sort of an abrupt shortness of breath and a different echo finding, which was more significant regurgitation on the mitral side than before.
So Molly, I'm going to put you on the spot. How would you handle this?
Well, I'm still trying to figure out a little bit. I mean, if this person had severe pulmonary hypertension and only mild TR at the time, I mean, I'm still trying to figure out what this underlying disease, like what caused that. I mean, does this person have primary pulmonary hypertension? I mean,
yeah, I believe so. So COPD as primary, and then a recent history of COVID, and also asbestosis. So 3 different etiologies of pulmonary disease. It was restrictive on PFTs. Was a finding, but
yeah, I mean, so initially I would have probably done the same thing. We would have tried with mitral clip because it seems like a pretty high risk for surgery, both liver and pulmonary hypertension that's not caused because of the valve. It wasn't valvular pulmonary hypertension, and I probably would have done the same thing. Now that he still has severe
what was the immediate result from the procedure? I mean,
so the report from the procedure there was it was mild to moderate MR and no significant TR or anything else.
Was this originally done elsewhere? Is it? Got it.
Well, Gorav, for the sake of time, let's see. Why don't you see if you're going to do the tricuspid repair?
Yeah, maybe we take a vote.
Yeah.
So clearly, you're going to do something to the mitral valve. Maybe you're going to try to take the clips off since it's only 3 weeks and try to repair it depending on the etiology. I don't know if we can tell enough, or if Becky has any thoughts. I know it's just a single picture. It looks like there are multiple jets. I don't know if there's a perforation as well.
Yeah, that's what I'm wondering. Was there like I don't know, did they rupture a cord? Was there something else? Because that just, it's kind of strange.
I'm sure Leora would be able to tell us.
The full echo for you, Becky. That would have been more interesting for you, but there were multiple jets across, and it did look like there was perforation as well.
So you may not be able to repair it. You may or may not.
Yeah.
So now you can have. It's like, and then the question then becomes, in the at least of the panelists, who would think that we should put a ring on the tricuspid valve, which now has moderate TR in the setting, I guess, with some liver disease and certainly pulmonary hypertension. Jim, what do you think?
My practice would be to repair the tricuspid.
Yeah.
Yep.
Yoshi?
I would. I'll be concerned with the pulmonary hypertension, and with the exacerbation, I think the RV is going to tire out if you don't repair that valve.
Molly, sounds like you're.
Yeah, I think that I would ask you guys to now repair the tricuspid, but in the original presentation with mild tricuspid, I'm not sure I would ask you to, and I think that's what the new data that came out just recently.
Don't leak the secret yet. I think we're going to move on to Jim's presentation now. I think a lot of people were anticipating this. So, Jim, do you think you can share your slides that was just presented at the HA?
I'd be delighted to, but if I may ask the group a question, originally with the initial presentation, who would have operated on that patient and who would have sent him to MitraClip, and who might have enrolled them in a prospective randomized trial to try and answer that question?
Yeah, it seemed like a perfect patient for, an intermediate risk type study,
Yeah.
if you will. And we know that there are some going on right now to compare clip to surgery.
And again, some of the liver disease and the lung disease is very, very difficult to assess at that time. But I think I would try to randomize. I think that's where the equipoise is.
Well, if the pulmonary hypertension was greater than 70, you wouldn't get it in any trial.
You're right.
Yeah, and unfortunately, I don't have any of the specific data on the initial presentation of that one.
I think that patient would be pretty low risk for conventional surgery. I don't. So I'll just jump in. Thanks for your input on that. I recently presented this at the American Heart. This is a trial that's been in the works for a long time, and it was really a privilege to present on behalf of the CTSN investigators who did terrific work here. And this trial was really was started around the question of what to do with a patient like this with moderate TR. And we looked at this when we started the trial in the STS database, and across the country, a patient like this with moderate TR would have their tricuspid valve fixed 40% of the time. So there clearly was equipoise about what to do. And I think you all know that it's a really controversial issue, and the rate of concomitant tricuspid valve repair can range from anywhere from 5% to 70%, depending on what institution you're at. So that was the background that we did the trial on. And as Gorav alluded to, the current guidelines are sort of a 2A recommendation, both European and American, to fix the tricuspid valve, particularly in the presence of annular dilation, defined as a diameter above 4 centimeters. And that's during diastole from an apical forechamber or a index to body surface area above 21. So the trial was focused on DMR patients. This was just a brief reminder of what the trial looked like. It happened in the US, Canada, and Germany. And if you had degenerative MR and you had either moderate TR or less than moderate TR with tricuspid annular dilation, you were allowed to be in the trial. And, one thing that we were able to control for, by and large, was the surgical approach. And we used undersized, defined as 26 to 30 rigid non-planar annuloplasty rings for all patients. And so we randomized 401 patients, 1-to-1 allocation, to either undergo isolated mitral surgery or concomitant tricuspid valve repair. And the main endpoint was a composite of death, reoperation for TR, or progression of TR, which was defined by severe TR or increased by 2 grades. And that was a 2-year endpoint. And we had Judy Hung and her group at Mass General did the core lab adjudication. And there were a number of clinical and echo quality of life secondary endpoints that you can see here. So this is what the trial looked like. A typical population of patients with degenerative MR, they were in their late 60s. Approximately 44% of them had atrial fibrillation. They had preserved ventricular function. The moderate TR group made up a little bit over 1/3 of the patients, with the remainder of them having less than moderate TR and annular dilation. Most of them had good RV function. The operative approach was sternotomy in half the patients. Interestingly, and worth diving into, is the fact that about 90% of patients were repaired, 10% were replaced, about half had concomitant procedures. We found the bypass time was 34 minutes longer in the group that had concomitant tricuspid valve repair. So this is the key primary endpoint. And you can see that at 2 years, the endpoint was substantially, significantly more common in the isolated mitral surgery group as compared to the concomitant group. And in fact, no patient in either group needed a reoperation for TR. Death was pretty uncommon and similar in the two group, and the primary endpoint was driven by TR progression. And I'll have a little bit more information on that coming up. We did a post hoc analysis that was not pre-specified, but it was to sort of inform our results. And we divided the groups into those with the moderate TR at baseline on the right and less than moderate on the left, and did not see a difference in the primary endpoint in the less than moderate TR group. And in fact, in both of those groups, less than 1% of patients had progressive or severe TR. Whereas in the moderate TR group, 14.5% of patients in the isolated mitral valve surgery group had progression. 0 patients that were treated with an annuloplasty ring had progression. This slide demonstrates the progression of TR over time. You can see that there was an immediate difference on the predismissal echocardiogram. If I can draw your attention to the right, at 24 months, the patients with severe TR, which were light red there in the bar graph, 5.6% in the mitral valve surgery alone group, and only 0.6% in the combined group. And if you look at moderate or severe, so the yellow or the light red, a quarter of isolated patients had either moderate or severe TR at 2 years, only 3.4% in the combined group. The cost of this was an increased pacemaker rate, 14.1% in the tricuspid group and only 2.5% in the isolated mitral valve surgery group. We saw no difference in clinical endpoints of mortality, adverse events, readmissions, quality of life, functional status. And patients seemed to stay in the hospital a few days longer in the US and Canada. So our conclusion was that tricuspid annuloplasty in patients with moderate or less TR decreased treatment failure. This was driven by progression of TR in the moderate TR group, came at the cost of an increased risk of pacemaker implantation, had no impact on adverse events, survival, or quality of life. These patients were relatively young and have a long life expectancy, and the plan is to continue to follow them. And I think it will be very interesting to see what the 5-year data show. And these were the sites, and a big shout out to the data coordinating center, the patients, and the team that took care of them. So I'm going to stop there, and thank you for allowing me to share that data on behalf of our team.
Jim, that was great. I want to hear what the cardiologist reactions are to this first. So Molly and Becky, maybe start with Molly. What's your reaction when you heard this?
Well, so I kind of had the feeling, to be perfectly honest, that mild TR was probably okay to leave, and that moderate and severe needed to be fixed. And it's kind of what I think our practice has been at our hospital. So it was nice to know that that was, was borne out. But what was surprising was or maybe not surprising, but concerning, I should say, is the pacemaker rate. And because we all know that pacemakers are not benign. And so, I'm not sure what to make of that. So you're trading off an increase in TR for an increase in pacemaker rate, which is also associated with mortality.
Right. Jim, what do you think about that pacemaker rate of 14%? Do you think that was a little higher than our standard practice?
It's interesting. In a national group from El Cooley at Mayo, the pacemaker rate was about 11%, There are some single centers that report much lower pacemaker rate. For example, Joe Chikwe presented a few years ago around 2 or 3%. So it's interesting, and the network is planning on doing a deep dive, and Gorav and others will be involved in that analysis. And we look forward to perhaps identifying some of the risk factors. I will share with you that a lot of those pacemakers were put in the first day or two after surgery. And so there may be, I think that what a couple of things stand out for me in this trial. Number one, I'll point out that, the mortality rate for surgery in these patients was less than 1%, the perioperative mortality rate. So it was outstanding. And even at 2 years was 4%, so 96% survival at 2 years. This is the gold standard surgery. And I think that the undersized rigid annuloplasty ring was remarkably effective at preventing recurrent TR. If you look at it, much better than an undersized ring in the mitral position for someone with functional MR. And I guess I would say that it behooves us to look at the management of these patients and maybe some of our technical aspects of what we're doing. So hopefully we could get the benefit of fixing that tricuspid annulus and preventing progressive TR without the cost of that pacemaker. So it remains to be seen, and it's a very interesting question.
Jim, there was a question, just you mentioned the ring. If you can confirm that they're asking if it was a solid or a flexible ring. And in the trial, it was...
Right. Rigid rings. I think there were 3 or 4 commercially available rings that were allowed in the trial.
And in terms of undersizing, there was not a standardized method to undersize. It was up to the surgeon's discretion, but only 3 sizes were allowed: 26, 28, and 30. And no larger ring was allowed, essentially.
That's right. And I believe it was the average ring size was 28 in men and 27 in women, or 29 and 28, something like that. But so the protocol was by and large followed.
Right. And there's some questions in the chat. I think that we'll need to do a deeper dive about the timing of the pacemaker. And you've already alluded to that might have influenced maybe a higher pacemaker rate than what one would expected. I guess I would add, the CTSN in the past has done a trial in AFib ablation. And when you do a biatrial maze in the setting of mitral valve surgery for patients with persistent AFib, the pacemaker rate is actually higher than this. It's 20 if you're doing a biatrial maze. So, the one thing that we'll need to look at is when we add a tricuspid, did surgeons end up doing a biatrial maze, and could that have influenced some of the pacemaker rates? Molly, any other thoughts on your end? Becky, on your end?
Yeah, Becky, can I ask specifically about the dimensions? I think that was the subgroup analysis that really had an impact from this study of measurement of 40. I think there was another question about the question of index, and how accurately can you measure this annulus of 40 millimeters with an XR?
That's a really good question, because in all honesty, we've learned a lot from 3-dimensional studies that show that obviously it's a 3-dimensional structure. And so when you're trying to measure something from an apical 4-chamber view, if you just tilt a little and do a focused view, or, we have 3 different RV views now, you're going to get completely different numbers. In addition, we know that ventricular functional disease is going to dilate differently than atrial functional disease. And so, you get one that dilates more out the anterior lateral, the other posterior lateral. And so, it's a 3-dimensional structure. And to think that a 4-centimeter annular size, whether or not it was indexed to body size, is going to represent the entire annulus. It's just folly. And so at some point, I think we will be hopefully changing to more 3-dimensional analysis of annular dimensions, because multiple studies have shown that annular size actually determines tricuspid regurgitation severity. And that's just been shown recently with 3-dimensional studies. So it's really right atrial size and annular area that end up determining TR severity. And that makes sense, right? Because the bigger the area, unless you have enough leaflet growth, you're not going to cover the area. So I think it's just that a linear dimension is just not going to be accurate enough. The only other thing to ask Jim is that I think we need to take the results with a little bit of equipoise, because this was a degenerative mitral regurgitation that you were repairing, and so consequently the etiology of the tricuspid regurg might indeed have been primary, or more often primary than secondary to any kind of post-capillary pulmonary hypertension. And in that setting, we already know from outcome studies that the outcomes, mortality, as well as heart failure hospitalizations, is less in patients with organic disease compared to those with functional disease. And so I do think we're talking about different patient populations, and you are going to need that long-term follow-up in order to see the outcomes in a more degenerative population. I don't know if you have any comments about that.
I think those are great points. Thank you.
Yeah, Becky, I'm curious. I mean, you brought up this interesting concept that I think that many of us see in the OR, but we haven't necessarily described very well. You know, we've learned that for MR, there's different varieties of functional MR, you know, being ventricular versus atrial. And I think that's also very true on the right side as well with TR. And I think all of us see patients with AFib for a long time and their tricuspid valve is dilated. They may have some degree of TR or a lot or none. And those seem to be very different valve morphologies and tissue quality than those that are tethered from RV dysfunction. So I think we need to get smarter about that. And I would say that, you know, to be in this trial, we didn't necessarily discern that to that degree.
Jim and Gorav, there was a question from the audience. So what was the incidence of worsening MR in the group with worsening TR? You know, TR could be a product of mitral valve disease. So how many of them had worsening MR?
You know, can I take that one, Gorav? Gorav,
Yeah,
was
go for it.
your author on this paper, so I don't want to. At 2 years, 10% of patients had moderate or severe MR, and we have not done the analyses yet to see if there was a correlation with recurrent MR and recurrent TR. So stay tuned for that analysis. It's a good question.
Yeah, and you know, I do want to state, like, someone like this honestly could have been in the trial, even as you presented, Leora, because the patient does have degenerative MR. It's likely not necessarily a repairable valve, or it'd be a heroic repair that you might have undertaken, and knowing you, that's probably the case, but, you know, or you would have tried. But a patient like this could have actually qualified for this trial and very likely would have gotten replacement. And that's why there might be some skewing of the results. It's not, the trial didn't say that has to be a repairable degenerative valve. They just have to have a degenerative mitral valve as their etiology. So we'll have to delve into that more. Another question that looks like it came up, and there's a lot of questions, Jim, you and I have talked about that, you know, all the audience is very interested in the technique of tricuspid repair. Was it done with a beating heart, off pump, pump assist or heart clamped? Yeah, and, you know, does minimally invasive versus sternotomy, all those factors, how do they play a role? Some of those patients may even had a pacemaker, right, already. So how does all that play a role in the outcomes that we see? And clearly we haven't done those analyses yet, but it'd be really important. I don't know if I'm curious what the surgeons here do in a concomitant case like this. Do you do it, Jim, Leora, Yoshi? Do you do your tricuspid valve with a beating heart or not, or
Typically,
or does it depend?
Typically
Yeah.
beating heart.
Usually beating.
Yeah.
Yeah. It depends though. I mean, you know, if it's along with another long set of case, you know, operative things to do, then I'll usually do a beating heart. But if I think there's going to be something more complicated with the tricuspid where I'm looking to do any leaflet repair or something different, then I'll wait and not do a beating heart.
Jim, what do you think?
I do an arrested heart. I think it's easier for the residents to do it when there's not quite so much blood in the field.
I mean, do you think there's a difference in the pacemaker rate with that? I mean, you know, one of the benefit of beating heart is that you can actually see the rhythm.
Yeah, I totally agree.
Yeah. That's one of the things we're going to look at. And we certainly know that some of the sites did do beating heart and some did, because you could look at the cross clamp and the bypass times and see a discrepancy. Yeah. So that's a great question. And maybe we'll find in going back over the op notes and doing that analysis that beating heart is the way to go. How often do you all put a suture in and see the conduction stop and then take it out? Does that happen often?
It can happen. Mm-hmm.
Not often, but I've done it. I've taken it.
I'd say
take it out.
What can happen is you might not see it right away, but as you tie it down, sometimes you see some changes, but I've also had patients where I've done a beating heart, the rhythm's fine, and then 2 days later they have heart block.
Yeah.
Right.
So what do you think about pacers in that patient population? And now you're do you do leadless pacers? Like what is your approach for folks who need a pacemaker 2 days post-op?
I
Well,
mean,
like that's a loaded question, because is anybody willing to put a pacemaker that early? And but assuming they need a pacemaker at a week or something, what do you guys think? What kind of leads are you putting? A standard lead? You putting a lead under echo guidance, a leadless coronary sinus lead? And then we can ask Becky what their experience is from the transcatheter side.
Well, I'm actually just wondering what happened in the trial. Did they do, I'm assuming they did RV.
Yeah.
RV,
We don't
and
know
it was-
yet. We'll get back to you on that.
It was really up to the site's discretion. So
Because
Yeah.
then the question becomes at, a 14% pacemaker rate and a 14% progression rate, are they related? Because, we know that, at least in our experience clinically, that it takes somewhere between, it takes a little while for you to develop tricuspid regurg, but it really all depends on, because of the fibrosis aspect, but it all really depends on where the lead is sitting. And it could cause regurgitation within 2 years. Typically, we've seen it at about 5 years.
We didn't
Or
see
severe
any,
TR at 5 years.
yeah, the progression didn't happen in the tricuspid annuloplasty patients. It happened in the non-annuloplasty patients. And it's interesting, we know from the literature that these people who have a pacemaker put in something like 30 to 40% of them 6 months later are not pacer dependent anymore.
Yeah, that's true.
So-
I know in our transcatheter world, we try not to cross the tricuspid valve with the lead after we've just put a valve in or something.
after you
like
spent a lot of time fixing it and making it look pretty.
Yeah.
So most of the questions now in the chat relate to what do we do now? So Jim, Yoshi, Leora, what are you going to do now today with this hot data that just came out, both with somebody who has moderate TR, no pre-op pacing issues, and let's say they're low risk, at least on paper, they don't have a secondary heart block or a YQRS or any type of vesicular block. Let's say moderate TR and versus just a dilated annulus. How are you guys how's this changing your practice or affect your practice? Jim, you want to start?
I want to be careful not to get out in front of my skis and really just, go with the data that we've presented. So I think that the data are informative. My takeaway is that as we wrote in the paper, that it calls into question the reliance on tricuspid annular dilation as a indicator for doing something to the tricuspid valve. And I couldn't agree more with what Becky said, that the tricuspid is such a complex three-dimensional structure, and the notion, the Dreyfus notion of relying on the diameter probably doesn't cut it. And it's certainly, while we really weren't powered to do the sub-analyses that we did, you can't help but looking at the less than moderate group and seeing virtually no progression in the untreated group and say, that's probably not necessary to do that prophylactically. My approach has always been to be aggressive. If there's moderate TR, and for the audience, you always look at TR over time, and the decision should be made before the operating room, how much TR there is in a non-anesthetized state. And, I have always treated the moderate TR, because if these patients come back with severe TR, that's a real management problem, and you don't want to reoperate on them, things like that. So it hasn't really changed my practice a lot, but it certainly is informative, and we still have more to learn with those additional analysis we talked about.
Yoshi, do you feel different in any way?
I have treated a lot of annular dilatation with a ring, even if it was mild to moderate. But I think I'm going to stop doing that based on this data. The moderate, I think one of the parts that did bother me was that even in the repair group, the quality of life didn't really improve based on the scores. Not just the mortality, but the KCCQ, I think, were similar.
You mean when you compare to tricuspid repair group versus everybody's quality of life improved in the entire trial.
It did.
Improved a lot.
But I think that was from mitral, right?
Yeah.
And it didn't improve from the tricuspid, which was a little surprising. But at the same time, a lot of the patients that we do mitral valve repairs do live longer than 2 years. So I think there's a benefit to repairing the moderate TR. So I will continue to repair the moderate ones moving forward.
Leora, how about you?
Yeah, I agree. I think it's interesting, and I do think that we have to follow this group out maybe a little bit longer. My primary role is in the functional group, so LVADs and heart failure, and so they also have a lot of TR, but maybe for different reasons. And I'm always impressed with how when you correct their left-sided dysfunction with an LVAD, for instance, and their TR does improve or stay stable in the majority of patients. But there is a subset in whom it doesn't. And in those, it's actually really interesting to watch what happens to their right-sided function. So this trial is obviously very different, and I do think needs to be followed out maybe a little bit longer for a variety of reasons. I'm hesitant, as you know, to sort of overdo things as just a baseline. and I worry about a 14% pacemaker rate. I don't think that we're doing anybody any favors if we have a pacemaker rate that's that high, particularly if we're going to end up putting a lead across the valve in a very healthy population that's going to live a long time. And so, I would have to look pretty closely at that. I think moderate, and if you can prove maybe one other thing that's going on, either liver dysfunction or some pulmonary pressure, something else, some other indicator, then I do think that it's warranted in the moderate population. But in the absence of that, I think I'd be hard pressed.
So even in a moderate, you wouldn't necessarily, unless there are other factors. Interesting.
I would look for other factors.
Yeah, well, this will be interesting, Jim, to see how not just the sub-analyses, but the longer-term data play out.
Absolutely.
It's going to be super important. Leora, do you want to tell us what you did with that patient?
Yeah, so if this is my partner's case, and in full disclosure, and so what they did, and I don't know, maybe I'll share my screen just briefly for another 2 slides or 1 slide here, just to show you the end result. If that's going through. So essentially, the mitral valve was able to be repaired. It had torn off of the annulus in the area of A1. And so that was repaired back to the annulus. And then obviously the clips were removed, and the P2 was resected and then a ring placed. And this is sort of the final result on the mitral side there. And then in this case, the tricuspid was ringed as well. With also a nice result, and then they ended up closing the ASD. So both sides were repaired.
Right. Did you say that the valve was torn off the annulus?
One of the leaflets. So I think that what the acute presentation was probably one of the clips. The leaflet had actually torn. Sort of at the.
It didn't tear. Okay, didn't necessarily rip off the valve from the annulus, but the where the leaflet was attached, the valve tore there.
Yeah, well, no, actually at the annular level, like there was some disruption there that needed to be repaired.
Huh?
Yeah.
It's pretty violent clip somebody put on.
All right.
Yeah,
Have you seen that before? Molly, Becky, have you seen that before?
Well,
Yeah.
we had one that we actually tore the leaflet off, and there's no question that the leaflet tore off. It was just bad, bad tissue, I think.
Oh yeah, I've seen that before.
Yeah. Functional ones more rather than.
I haven't seen it rip off the annulus.
Functional, yeah.
Yeah, functional. Good point. Yeah, it has to be a little.
And the only other question is, what devices they put in, because we know that as you start to get toward the commissures, you probably should stay away from the long clips, so like the XTWs, because they just don't have the same force at the tip, and they can just kind of tear everything. So, just curious as to the technique that was used.
Yeah, absolutely. I don't have those details.
All right, maybe for the sake of time, we should move towards the transcatheter side, Gorav, don't you think?
Yeah, go for it.
Okay, Molly, do you want to present what's really hot in transcatheter tricuspid world?
Yeah. All right. Let me share. So is interesting is because I was told I had 7 minutes to talk about transcatheter repair and replacement, and at TCT I had 7 minutes to just do replacement. So this
I heard that talk and I knew you could do it. So.
All right, so this will be interesting to try to get that through. So I'll kind of fly through.
Take a little time. It's okay, Molly.
All right, and I will have to say that I stuck to TEER and replacement, so I really do not have much on annuloplasty. But so for TEER, this is what is been going on the tricuspid percutaneous side. That is a little bit. We have a little bit more data than replacement, and we have more data with the mitral clip. This was all born out of doing drive-by tricuspid work when you're doing the mitral clip for the mitral side. So it led to the Triluminate study, which is a dedicated tri-clip for the tricuspid side, or I should say it's the same mitral clip, but the delivery system is dedicated for the tricuspid. And the objective of this was to evaluate the safety and performance of the tri-clip in patients with symptomatic moderate or greater tricuspid regurgitation. This was a prospective single-arm multi-center trial in 21 sites in the US and Europe. The primary endpoints for this were effectiveness, TR reduction of at least 1 grade at 30 days post-procedure, and then a safety endpoint, which was a composite of major adverse events at 6 months. And then you can see the eligibility. And so severe hypertension or severe pulmonary hypertension is excluded in almost every study. And then the inclusion was moderate or greater TR, so not just severe TR. And so this is the mitral clip in the tricuspid position. That was before. This is after the mitral clip was placed, and this one actually had 2. And let's see if this thing will play. And so had pretty good reduction of TR. I'm not sure that anybody has complete reduction of TR, but at least it gets down to, you can get it down to hopefully mild. So the Triluminate study at 30 days and 1 year showed a sustained reduction in TR greater than or equal to 1 grade in 87% of the patients, and the initial reduction of TR was sustained in 79% of patients. Functional class had also improved. It increased to 1 and 2 from only 31% to 83% of the patients at 1 year. So a pretty good increase or decrease in functional class. Increase in functional class. So there was also early signs of positive remodeling in the right atrium and right ventricle. So it had benefit to the actual integrity of the right ventricle. So the next leaflet or tier device is the Pascal, which is a central spacer that actually bridges the coaptation gap. It elongates, so it's a little bit easier, I think, to navigate in the dense chordae that we know the tricuspid has. It has a nitinol design. It was the first device that has independent clasps, so you can really optimize leaflet placement, though now the mitral clip also has independent grasping. And it has this Pascal ACE, which I think we have begun to use only the Pascal ACE in tricuspid because it has a narrow profile and can get around to all those chords. All right, so this is what the clasp looks like. This was pre, this was in the EFS. And this is post with 1 clip and got a pretty good reduction. So the EFS trial enrolled 63 patients, predominantly female, and it had very good success rates. The implant rate was 100% successful. And at 30 days and 6 months, mortality was pretty much the same, 3.2% at 6 months. And bleeding was 6 and then 8%. There were significant improvements. 89% achieved a greater or equal to 1 grade reduction. 70% achieved a greater than or equal to 2 grade reductions at 6 months. And then there was also an improvement in functional class. 84% improved to 1 or 2. NYHA 6-minute walk improved, and the KCCQ scores improved as well. So this was a favorable 6-month results with high implant procedural and success rates. There were low complication rates with significant TR reduction, and more importantly, an improvement in symptoms and quality of life. So this has led to the Class 2 TR trial, which is ongoing now. This is a prospective multi-center randomized control pivotal trial. It's the Pascal system plus optimal medical therapy to optimal medical therapy alone. Optimal medical therapy is really just progressive diuretics. The primary endpoint is at 24 months. It's a hierarchical composite endpoint of all-cause mortality, heart failure hospitalizations, and need for surgery on the tricuspid valve, as well as improvement of quality of life. And like I said, this is ongoing now. It's for patients with symptomatic severe TR, so not moderate, but just symptomatic severe TR. Moving on to transcatheter tricuspid valve replacement. So there's really two types, though we do the orthotopic more than the heterotopic. The orthotopic means the valve is deployed at the tricuspid annulus. Heterotopic means that the valve is deployed in one or both of the cavas. So we'll talk about orthotopic first. The one that's farthest along is the evoked tricuspid valve. This was also taken from the mitral side, though now the mitral side has the next generation valve, which is the EOS. This is still the I guess third generation evoke. I think EOS is now fourth generation. It's a unique valve design in that it engaged the leaflets, the cords in the annulus. It has these atraumatic anchors. It has a conforming frame. It has multiple sizes, 44, 48, and 52, which is great because the tricuspid annulus can be very big. And it's only a 28 French delivery system, which is compatible with all the different sizes, which is pretty nice. The EFS trial was the TRISCEND study. This was with symptomatic greater than equal moderate tricuspid regurgitation, so moderate and severe. And the endpoints were device and procedural success, TR reduction, and a composite of major adverse events at 30 days. Follow-up was 30 days, 6 months, 1 year, and annually through 5 years. 56 patients, also predominantly female, which I do want to talk about after that all these patients seem to be female. Significant reduction in TRs was achieved. There was 98% reduction in TR severity to non or trace at 30 days. 100% achieved greater than equal to 1 grade reduction, and 95% achieved greater than equal to 2 grade reduction at 30 days, which is pretty good. The complication rate was low, though there was severe bleeding that happened in 22%, but none of the severe bleeding were life-threatening, nor were they were fatal. There is an improvement in quality of life, as you might expect. There's 77% had New York Heart Association 1 or 2. There was an increase in 6-minute walk and an increase in KCCQ. So across these 9 sites, there was a huge severe NTR reduction with a pretty low complication rate. So this has led to the pivotal trial, which is patients with severe TR or greater. And it's also randomized to optimal medical therapy or optimal medical therapy plus the evoke device. The same follow up 30 days, 3 months, 6 months, 1 year, and annually through 5 years. And then your primary endpoints are what you would imagine: TR grade reduction, and then a composite of KCCQ, New York Heart Association, 6-minute and 6-meter walk. There was also a primary endpoint of major adverse events at 30 days, and then a composite endpoint of all those things that are listed there. The next tricuspid valve replacement is the cardio valve, also which came from the mitral side, also transfemoral and transseptal. I don't care what Paul Saraja says. I would much rather have a transseptal device than a transapical device any day.
That means you don't like Rob Smith's suturing skills. Come on.
Right. This is a robust frame. It also has a small, medium, large, and extra large. So it goes up to 55 millimeters. There's proprietary anchoring without any radial forces, and it has a PVL sealing cuff. And they have just recently started their tricuspid EFS trial. So this is TR pre and post on one of their patients with pretty good outcomes of reduction in TR. That was acutely. This is 30 days. It sustained its TR reduction with no paravalvular leak. And then you see the 3-month follow-up with reduced TR as well. The next one is the Intrepid valve. This was also designed for mitral. As you can tell, most of these things came from the mitral side. It is a outer stent with an inner stent, so you don't really have to worry about rotational alignment. It only goes 42 and 48, and it's both transapical and transfemoral, mainly because of the mitral side. This is the delivery system. Actually, all the delivery systems kind of look like each other. They're very big and bulky. This is the deployment of Intrepid. Again, this is early in first in man and EFS trials. And it just sort of releases, expands and releases. So it's not a difficult deployment. It's multi-directional, as most of these devices have to be multi-directional steering so you can get it in, but it is 35 French, which is, even though it's venous, it is still pretty large. And so they have a 30-patient EFS study that is ongoing. Now, heterotopic, I don't think is going to gain much ground, but I may be wrong. The idea behind it is that it reduces venous regurgitation and improves hemodynamics that way, but it ventriculizes the right atrium. So this ends up being more palliative because the RA just can't handle that. The risks are thrombosis, embolization, and covering the hepatic veins. The Sapien XT was the first to be used. It was deployed in a cover stent in the IVC. Otherwise, it wouldn't stay in place. As well as the IVC is pretty big, and so we needed a stent to be able to put a 29 Sapien into it. The tricaval trial, which was looking into this, was ended early due to dislodgement, but they have a hover trial that is ongoing. And then this was kind of interesting. This is the Tric valve, which is also in EFS right now and ongoing. It's mounted on nitinol stents. And so they have an SVC valve that's kind of a longer skirt that's implanted in the SVC to reduce paravalvular leak, and then a shorter skirt in the IVC valve to reduce paravalvular leak as well, but also reduces the chance of covering the hepatic veins, which is a big thing that they worry about. The primary endpoints are adverse events at 30 days and New York Heart Association. So that's all I've got for repair and replacement.
That was a lot and super exciting. There's a lot that's going on in this field, but I think one case is worth 1,000 words. Becky, you want to show your case?
Yeah,
sure. I'll let me know if you can see the slides. All right, we're going to hope for the best here. It's a really big file, but can you see them?
Yes.
Okay, great. So this is our patient, 84-year-old, very slight female. She's in New York Heart Association class 4, relatively low blood pressures. You see her STS score, but her frailty score was 6. So, she was frail, although she could walk 348 meters in 6 minutes. She had a number of different comorbidities, including atrial fibrillation. A lot of the patients, obviously, in all the trials have atrial fibrillation. Also, heart failure with preserved ejection fraction. She also already had a pacemaker put in. Her right heart cath showed pulmonary pressures of only 50, so elevated, but not wouldn't exclude her from any device. She's on the usual medications, including 2 types of diuretic, and then also on an anticoagulant, so apixaban. She has pretty good renal function, and then you see that her BNP is indeed elevated. These were her initial images, just transthoracic. You could see the pacemaker in there. She's got tethering, massive dilatation of the right atrium in the setting of atrial fibrillation. And the initial transesophageal you can see here also, but I'm going to show you the another baseline. Hopefully it'll show up. Imaging here. Just to show that indeed, despite being in chronic atrial fibrillation, there's really no significant mitral disease, and it's all dilatation of the right atrium. Some older studies suggest that's actually a not uncommon pattern. Her RV function was indeed somewhat reduced. We have an RV strain here of -15. Not infrequently in the setting of tricuspid regurg, we might expect that to be hyperdynamic, but it's not. So now just our standard views to get a good assessment of the extent of the regurgitation. This is a sweep across the inflow-outflow view from the anterior to the posterior tricuspid annulus. And as you sweep across, we're basically imaging the entire coaptation zone with the septal leaflet. Again, most of the dilatation occurring either out the anterior lateral or the posterior lateral annulus, and therefore pulling away from the septal. These are the gastric views, which we like to use, and you can see now that there's extensive chordae across the entire coaptation zone, just everywhere you look. And that regurgitation, again, has a long anterior-posterior length and a shorter septolateral. Three-dimensional imaging shows the same thing. It doesn't look as though we have any impingement by the pacer. So a lot of the pacers are incidental. And this is all still what we think is kind of end-stage atrial functional, which then becomes tethered. The 3D vena contracta area was torrential. So this is 1.6 centimeters squared by just planimetry of the color Doppler jet. And then the question to the panel is, what are the treatment options? So I don't know if anyone is going to opt for isolated tricuspid valve surgery versus transcatheter. We've already hopefully optimized medical therapy, but the patient
maybe
remains
a fair
sick.
question, Becky, is, prior to the advent of these transcatheter devices from the surgical group, how many would offer her an operation, and what would you do? Would you try to repair it? Would you replace it? I don't know. Leora, Jim, or Yoshi?
Yeah, I think it's interesting, with the advent of these trials, I feel like, at least for me on the surgical side, I see way more of these patients just in general. I think initially, if you saw an isolated tricuspid patient, they would already be in very advanced RV failure. But now I'm seeing them sooner where their ventricular function is still intact. And so, we have a number of these trials ongoing, obviously, here at UVA. And so most people get shunted in that direction right now, but there are people who don't qualify. And so I've taken a number of them to the OR, and actually they do actually pretty well. So, and then to your question, I usually replace them when they're this advanced, what you're just describing here.
Yeah, I wanted to add because I think of the transcatheter work on the tricuspid valve, it has made surgery much, maybe safer and better in the fact that we know that you have to optimize these patients before you do anything. We know how to pick these patients, because when we look at our isolated tricuspid valve surgery data, the paper that we wrote in 2019 was, we had dropped our mortality down to 3.9%, which was way lower than the national average, where the next lowest was 8%. And then after that was 11 and 15%. And now when we look at our last 3-year data, the mortality, was close to zero. So I think that the surgeons have learned a lot from patient selection, or at least we've gotten a lot of the education out there for people to send their patients, or at least look at it first and recognize that there's tricuspid regurgitation, and then send the patients earlier. So it will be interesting to know, surgery versus transcatheter, and who to do and who not to do.
I think those are great points. This patient, the RV function looked pretty bad to me. And I think you live or die by what the RV function is, and your patient does too. So this is not someone that I would offer surgery to. I think if the RV function was a little better, your question around repair or replacement, I find this a difficult topic. I think for your average patients that's having a mitral operation with moderate TR, easy, you ring and you're successful. For me, if you've got visible malcoaptation, I would absolutely move in the direction of a replacement. I'm curious, Yoshi or Gorav or Becky, do you have a different algorithm for when you replace and when you repair a tricuspid valve?
Oh,
I've certainly shifted to being more aggressive about replacement, especially in these patients. You kind of get one shot. And if we look at functional MR data and ringing, for severe MR, we know even from the CTSN trial, the outcomes are not great in terms of recurrence. I think that's matched particularly with ventricular tricuspid regurgitation and a lot of ventricular dysfunction and tethering. I think ultimately, I'm guessing we're going to get smarter about looking at the amount of leaflet relative to the orifice area. Because the atrial TR patients, they tend to have actually a decent amount of tricuspid valve leaflet, but the tethered functional TR from ventricular disease, they tend to be much like on the mitral side. They don't have a lot of valve orifice, or leaflet orifice area, I guess.
Jim, for the sake of time, I'll make it really quick, but my threshold for replacing the valve, if it's isolated, has gone really low because of the transcatheter tricuspid valve and valve. The tricuspid valve and ring does not produce good outcomes. So if it fails, valve and valve serves much, much better. So if there is a valve that looks like the repair is going to be, I would have very low threshold for replacing those.
Understanding that you have a pretty high pacemaker rate with replacement.
That is true.
There is a question in the chat about matrix tricuspid valve replacement. I'm assuming that the question is related to core matrix, maybe?
Core matrix, I'm
Like
sure.
a neo valve?
Yeah,
Is that something that you guys have done in like even in a non-endocarditis or endocarditis population? I certainly haven't, just because some of the data I've seen doesn't suggest it has great longevity, but it sounds like that's not, maybe a little too early for prime time. All right, Becky, you want to tell us how it went?
Yeah, sure. I did want to make a comment about the lower mortality rates that are being reported by single site studies. In general, those patients are a lot younger. There was one study that the average age was 56. So that's not the patient population that we end up treating. And it's just as Molly suggested, is that those patients are coming much earlier and therefore have fewer comorbidities. And I think the ones that we end up getting are ones like this, which are pretty sick. I wanted to point out that there's a new surgical risk score for tricuspid valve. I don't know if anyone's tried it, but this is from the Julian Dreyfus study coming out of France that showed the same mortality rate as the US studies by Zach and Al-Khatani, which had a 10% mortality rate. They then took that population and generated a risk score, surgical risk score, and it's up online. And so we did that for our patient, and our patient's risk score was super high at 14%. So she had already had the RV dysfunction, as Jim had mentioned, and so this was not going to go well. And so we opted for transcatheter tricuspid valve replacement over a TEER device, given the challenges of the chordal apparatus. So you saw those dense chordae, and we thought this was better. So I don't know if you can hear this or not. Can you guys hear me talking on the?
No.
Not very well. No. We're okay with live Becky talking too.
Yeah,
Okay.
it might be better.
You want to just describe it? I bet a lot of the audience haven't seen a Voc or any
but anyway, hold on one second. Yeah, so we're right now. I'm not going to go through the whole case, obviously. That would take us a long time. I might just come out of PowerPoint for a second, but we can. I was hoping we could skip to a bunch of the endpoints to show you how we're doing this, but this was the live case at TCT, and so within 50 minutes we were able to put in a valve, and we started obviously with just doing routine imaging and. Hold on, I'm gonna see if I can. I don't think I can. Oh yeah, here. So then this is just again showing the device. We heavily use multiplanar reconstruction in order to really speak to each other in the same language, and we align all of these planes in exactly the same way so that every time I talk to Sushil, it's the home view is this view, which is going to be posterior, anterior, septal, lateral. But when we're looking at the device and the anchors, we're going to just use this real-time multiplanar reconstruction to basically flip around and be able to go in a circle, see all 9 anchors. And so by being able to see all 9 anchors at all times, which you can see on the 3D also, we can be sure that we're underneath the leaflets, and the leaflets are coming over the top, and that the anchors themselves are within the annulus. Because it uses multiple mechanisms to anchor. This is not something that has times or anything like that. It actually has these hooks, as you can see, and they've come out now and are going to be gradually expanded. So the device is just gradually expanded as we're continuing to watch. Again, making that constant look at the using echo to redirect the device and make sure that we're centered in the orifice, and then continue to expand. And everyone in the room has to feel comfortable. We're again using live 3D to rotate around, and then we just continue to expand. And they've just deployed the valve here. So this is us having deployed the valve, and we're just going to help the interventionalists come out of the safely come out of the valve so that they don't dislodge it. You can see that the pacemaker is now exteriorized out the posterolateral side, and we've not had any cases that have had any change at all in their pacemakers. We have had a pacemaker rate that Sushil presented in the 6-month TriScend study of about 10%, so a little bit better than surgery maybe, although it's roughly comparable to many of the other surgical trials with tricuspid valve surgery. And in this particular case, we see that there's just a really small amount of leak around the pacing wire and maybe just a little bit around anchors. But otherwise, planometered valve area of 2.5 centimeters squared, really trivial, everything else. And then obviously we look at RV function. We worried about RV function. This patient did extraordinary. I mean, you can really see this RV function, which we were really concerned about, being minus 15. Normally a tricuspid is going to be well over 20 for strain, and did not turn a hair. I mean, normally they come way down, and because there's intrinsic mechanical dysfunction, this patient stayed right at 15, has done extraordinarily well. You can see that the reversal in the hepatic vein is basically gone. This is all just compliance issues as far as a little bit of reversal, but there really is a tremendous forward flow, as you can see in the hepatic. And we also showed that there was increased forward flow out the alveolar tract. So everything that we had hoped for in a transcatheter tricuspid valve replacement.
It's a great study and great result, Becky. So I just want a follow-up question. You know, there's this concept or concern that both cardiologists and surgeons have had, both on the mitral and especially on the tricuspid side. Is it better to leave a little bit of TR, or in some of these really, can you hear me okay?
Yeah.
Okay, good. Yeah, in these really advanced poor right ventricles, is it better to leave some TR, or complete elimination is okay and the RV can handle it? I'm curious, based on what you've seen.
Well, you just saw a result that
Right.
was relatively surprising, but I mean, that RV tolerated it pretty darn well. And so I don't know, there are valves that are being designed now to have pop off either actual defects that can be opened to allow some pop off with tricuspid regurg, or there's another valve that has this very, very big closing volume of maybe 5, even 10 cc's. That's felt to be able to afterload reduce those patients. And I just don't, nobody knows. I mean, Jim, you guys, what do you, you guys take away TR all the time.
Yeah.
You know, I would think that less TR is better.
Yeah. What do you think, Jim?
Yeah, I think it's the same as the mitral. You know, 30 years ago, people were saying, oh, don't take away the pop-off valve. We know that's not really true. And I think that probably holds true for the tricuspid. Although if you have a profoundly depressed RV function, I don't think you want to be doing anything to that.
I agree with that. I think
Yeah.
that's the key,
That's
is
it.
patient selection.
Yeah.
If you have a severe RV dysfunction, I think pop-off does help. So maybe those are the ones that you should be putting the clips on, you know, rather than
Nothing,
placing
or
that valve.
nothing, Yoshi, nothing.
Yeah, I was gonna say there might not be much benefit at all.
All right. I think we can go on for another hour talking about this, but I think we're about time. I think all the panelists probably agree that the next 5 years, we'll be talking a lot about tricuspid. I think it's the era of tricuspid, and I think it's a really, really hot topic. Thank you for everybody for the participation, to all the panelists, to the STS, and all the participants. And we look forward to seeing you again. Thank you very much.
Thank you.
Thank you, Yoshi.
Have a great night.
Thank you, Gaurav.
Thanks.
Have a good night. Thanks, everybody.
Good night.
Thank you very much for staying a little bit over time. And thank you to our moderators and panelists for your participation and insight. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. Register now to attend the STS annual meeting in January and be together again with the cardiothoracic surgery community. Early bird discounts are available until December 2nd. Go to sts.org/annual meeting to view the program and register. The STS Cardiothoracic Surgery ebook is now available for purchase. Online or mobile, it's the most complete and authoritative resource for CT surgical information in the world. The latest update of the ebook includes 36 new chapters in the adult and pediatric cardiac surgery volume. Learn more and subscribe at sts.org/ebook. Lastly, save the date for the next event in the STS Webinar Series. The program will address the new framework for quality improvement patient safety. Join us on Thursday, December 16th at 7 p.m. Eastern. Thank you so much and have a great night.